Hi, everybody. I'm Roland Regino. Welcome to the Kind Intel Solutions podcast, where technology is human centered and thoughtful, and our mission is to serve humankind. In each episode, we explore how innovative solutions and compassionate leadership are transforming healthcare operations. Join us as we talk with industry leaders who are redefining efficiency, elevating patient experiences, and are shaping the future of care. On today's episode, we welcome Dr. Matt Astin from the Macon Volunteer Clinic in Macon, Georgia. Thanks for joining me today, Dr. Astin. Before we dive in, could you give us a quick overview of your background and current role?
Yeah, thanks for having me, Roland. Like I said, Dr. Matt Astin, I am double board certified in emergency medicine and internal medicine. I've spent many years at Mercer University in Macon, did my training at East Carolina University in North Carolina. I'm here because I serve as the medical director for the Macon Volunteer Clinic, which is a multi-specialty primary care clinic in Macon, Georgia, but I also work clinically in the emergency department at Atrium Health Navicent, which is a level 1 trauma center in Macon, Georgia. I also serve as medical director for a couple of different paramedic training programs around the Middle Georgia area, as well as a Master of Athletic Training program at Mercer University. So I'm the team physician for Mercer University, as well as the Macon Mayhem hockey team in Macon, Georgia.
And on top of that, Dr. Astin's coming off an overnight ER shift, so we are very thankful for your time and we appreciate you being here.
Glad to be here.
With that, let's just jump in broadly. What are some of the biggest challenges you're seeing in healthcare delivery at community clinics?
And one of the biggest things we see at the community clinic level is access. A lot of people don't have insurance or are underinsured. So finding a provider to care for them is an issue. A lot of the private practices will not take insurance. They won't take people without insurance and won't take certain types of insurance. So a lot of these people fall through the cracks. So it's getting these people that have medical needs, getting the resources that they need to live a healthy life.
And your clinic is a fairly unique one, as we had mentioned before, volunteer and completely volunteer clinic. With that, has there been any adoption of technology or other best practices in your day-to-day practice in the recent years to help manage that workload?
So our clinic is, like you said, it's very unique. We were on a completely volunteer basis. All of our providers are volunteers. We have a couple of paid staff, and all of our funding comes through grants and philanthropic donations. So that limits on what kind of technology we can use because we can't really afford to pay for things. But that being said, we have partnered with a lot of technology companies to help with us. So our electronic medical record that we're using the free version that was donated to us from the company. So we also use a service called Care Message that works through that EMR to send text message reminders to patients, not only about upcoming appointments, but educational opportunities that we have, that type of thing. We are partnering with a new organization that provides, again, free services, but it's more of an after-hours type care. So our clinic hours are pretty slim just because of finding the resources to man this volunteer clinic. But this service, what they offer is a centralized phone number that patients can call after hours, and they will get to talk to somebody. And it's kind of a triage type thing to see if they can wait to come to the clinic the next available day, or if they need to go to an urgent care or an emergency department. The technology part that's beneficial for us is, even though that doesn't go into our electronic medical record, we do get a notification that the patient did call and what recommendations were made so that we can follow up on this, because that's a big problem that we have, again, with our patients just falling through the cracks and getting their medical care. So that's the biggest technological advance that we've had recently.
That's great. And you were saying that technology, it's sort of like a telehealth option,
Right.
and that's been donated to your clinic?
Right. Yeah, it is a telehealth option that our clinic is signed up with this organization. They run this for multiple volunteer clinics across the country. We're part of the National Association of Free Clinics in AFC. So and here in Georgia, the Georgia Charitable Clinic Network. So that's how we were able to get in touch with this company. We partnered with them. They providing the service at no cost to us or our patients. Yeah.
Wish them all the
Well, as I
best.
said, they're one of several that I have seen or heard about. So they are out there all across. Actually, this one all across the country. This one is mainly a Georgia-based thing, but there are places elsewhere. So.
Now, on the other end of that, in terms of, you're looking at some of the tools that you've used to uh, make the day-to-day more efficient. What inefficiencies have you noticed the most in your current workflows?
Again, it goes to the lack of resources. Our capital budgets are very, very limited. So get an EKG on a patient. What I get in the emergency room, quality and time, speed wise, is on a different level than what we do at the clinic. This is just
Mhm.
because of what we have. Getting some labs more difficult for us. Diagnostic studies. We partner with one of the local hospitals and radiology groups that we get free x-rays and ultrasounds. But if we have to advance to a CT scan or an MRI or any other type of imaging, that's a cost to us as at the clinic. We pay for that ourselves. We do not charge the patients anything for that. So we have to practice a lot of hands-on physical examination type things. So going old school with medicine on that part.
Mm.
We do get a limited number of mammograms for breast health at no cost to us. Now, when I say limited number, that number our need for that has not exceeded what they're offering to us. So those are the big things, is just access to the diagnostic studies that I need to take care of patients. The other inefficiency that I have is finding the appropriate specialist to see a patient. So we are a primary care clinic, but we do have multiple specialties with us. That includes, we have a neurologist that comes, OBGYN. We have a dermatologist that comes once a month and blows through 20 patients in 10 minutes. It's a whirlwind. But we do have a nephrology group that will see our patients for hypertension problems. But I do not have a gastroenterologist to do screening colonoscopies. I do not have a definite cardiologist that will see our patients without charging them for chest pain evaluations, those types of things. So we have to get creative about how to get the proper care. Orthopedics is a big thing. We have finally partnered with one of the local orthopedic groups that they will do the surgeries for our patients, but before that, the entire workup has to be completed. So a lot of times that includes, an MRI, that type of thing. So that's an increased cost for us and it just takes time.
How do you get the volunteers, and what are the requirements
Yeah.
and restrictions on getting volunteers to come and support your clinic?
So being a completely volunteer clinic, all of our providers give their services for free. So a lot of the times they are retired physicians that are seeing them, but we still see some that are in active practice. How we get them is basically just word of mouth and personal interactions with these people, with these providers. So the ones I've interacted with in the hospital setting or outside in some of the medical association type events. The other thing, as far as recruiting for us, our clinic, we just celebrated 20 years. I have not been with them for 20 years, but we've just hit 20 years. So it's in our community that's, several 100,000 people. We're known. So people know who we are. So I do have, not on a frequent basis, but occasionally I will get providers reach out and say, hey, I'd like to help volunteer. So the process for that is we have an application, so to speak, that gets filled out just so that they get covered by the state laws for volunteer work. Because as a volunteer, if you're not getting paid for this, it falls under Good Samaritan type laws. But we have to go through the process to make sure that they qualify for that.
Well, thanks for that background and context. I think it speaks to one of the challenges, and obviously the biggest challenges you have as a volunteer clinic is really getting that staff and support. In lieu of additional staff, do you see the use of other technologies that could help support your community healthcare? You had mentioned that you do have some right now, and those are donated, but are there others that you are aware of, other systems or technologies that you're aware of that could be helpful to your practice?
Yeah, so things that, potentially at some point, AI scribes, that type of thing could be very beneficial for us because, like I said, a lot of our providers are retired, so they're not as handy with the electronic medical record as, somebody that's just coming out of training. And, one of my biggest providers, he's always our top volunteer. He's a retired cardiothoracic surgeon, but he's doing primary care. That's not his specialty. Bless him, we love him, and everybody loves him. But I always I expect to answer a lot of questions from him, and I am happy that he recognizes that he doesn't um, have all the information. So AI scribe technology that could help is one thing. We also could use and seeing things as far as visual diagnosis aids. So we have a dermatologist that comes basically once a month and sees a ton of patients in a short time, but he's not always there. So, but we haven't been able to get the funding to purchase those types of things. We also, again, a lot of the specialty is not the right word, but kind of advanced screening tools that are used for things like liver disease or cardiac disease. So we have to do a lot of guessing and hoping and trying to use clinical decision tools. We just partnered with the American Liver Foundation to kind of help with a screening process for fatty liver disease. That's going to help us. They're going to be paying for the screening lab tests, and if we need to get ultrasounds on the liver. So those are the types of technology that will just streamline some things in our clinic to free up more time for us to actually talk to the patient. We'd like to get them, but again, without the funding to get them, it takes a little time.
Yeah, it's interesting you mentioned the AI scribe, and I could see that being really appealing to you and your clinicians on staff. As you mentioned, a lot of your staff are retirees, and I can't imagine that the one thing they missed about their day job was paperwork. So, so that I could see that being very helpful. Aside from the technologies, what do you see as the role of preventative care and how that's evolving in community clinics?
So this is one of the failures of quote unquote Western medicine. We have always been the curative type approach to medicine, where as opposed to the preventative side, our healthcare costs in the United States are skyrocketing. Well, it's because we are on the back end trying to fix problems that occurred. If we put the effort and the time into the preventative things, the costs downstream are not there. So that's where these community type clinics, we try and do the best that we can. We try and manage the blood pressures. We try and manage the diabetes to prevent the uninsured patient from going on to dialysis or getting an amputation or having a stroke, because if they don't have insurance, who's going to pay for that? The provider, or eventually they end up on Medicare or Medicaid. So that's a taxpayer type thing. Happy to do that if we need to, but if we can prevent it, not only is that a cost savings for the healthcare industry down the line, it's an increased quality of life for the patient as they go through their life.
Now, aside from preventative care, have there been any other strategies that you've implemented that have been most effective in improving patient outcomes?
Preventive care is the biggest one, but vast majority of our patients already have pre-existing things. So, the other thing that Western medicine prioritizes things is let's write a prescription. We're very heavy on medications, but again, with our patients, they don't have the money to get all of these medications all the time. So we have to do a lot, and we are able to do this with the way our model is one-on-one education. Um, you know, dealing with nutrition, dealing with lifestyle modification type things. Though, and we have with the new building we just moved to, we have a space to have an education room. We are actually starting community kind of education classes to help with food, diabetes management, that type of thing. So we are able to take that extra time that the normal private practice doesn't have to deal with these lifestyle type problems. We have the time to do it. I'm not under the pressure to see 30 or 40 patients in a day just to manage my practice overhead. It's not there. So that's one of the big thing that we can do. We can address these non-medication related interventions, for lack of a better term, to kind of help deal with the entire care of the patient.
It's interesting because the next question I had was actually how do you balance that quality care with the resource constraints? And it sounds like because you don't have that structure, that overhead to manage, you have more time, more bandwidth for the patients. And is that how you kind of balance that quality of care?
Right. That's it. We actually have using grant funding to pay for this person. We have a part-time kind of a care manager type position that helps follow up, make sure people are taking their medications to help them navigate our medical community with our strict criteria. We see patients that have a job, they have to be working, but they do not have any medical insurance, and they can't make more than 200% of the federal poverty level. So this is a very strict group. Therefore, if you are 65, you're eligible for Medicare, you can't be one of our patients. This person, a lot of people don't know how to deal with that. So you're 64 years old, about to turn 65, and oh, you're eligible for Medicare, you're not our patient anymore. They don't know how to get plugged into that community. So this care manager position is able to help with that, help guide them through that process. Also, people that go on disability or Social Security, they don't have the wherewithal to manage that process themselves. So we are able to help them navigate that process.
That's interesting. This care manager position, is that the role that you think is most responsible for maintaining that patient engagement and compliance and ensuring that your patients fit the strict criteria that you've laid out?
Well, the strict criteria is managed by pretty much everybody. We have a yearly recertification process to make sure you fall within our criteria. And, you know, sometimes I'll go to the emergency room and get in the hospital and get signed up for insurance and they don't know about it. So we can see that information when it comes to us. And so, a lot of times the insurance that a patient gets signed up for is not very good. They don't like it. So they will deny that. They will cancel that insurance just so they can stay our patient. So that's a clinic wide process to maintain eligibility for our patients. This care manager position, it's a fairly new position for us. So we are in the process of what we had on paper was the role that was going to be. We're kind of morphing that to what it actually is going to be.
Now let's look at the healthcare space broadly, and you having roles at the Macon Volunteer Clinic and your ER athletic director at universities. What trends are you seeing across healthcare delivery that excite you, that you see upcoming, that you're looking forward to?
So one of the big things is more on the hospital side, trying to get patients out of the hospital and not keep them as an inpatient, but to transition their care outpatient. So we're seeing a lot more effort and resources poured into community type things, whether it's a practice like ours or a private practice or private medical group, but trying to get that outpatient work done quicker, faster, and more efficiently than having somebody come to the hospital to sit there for chest pain, for example, to sit there 3 days, just sitting there, as opposed to I see them in the emergency room. A lot of places will see them, they will run this protocol where we check labs, check an EKG. If they're pain free and everything looks okay, we can send them. The guidelines actually say they can get a stress test within 72 hours as an outpatient. But it's just making sure they can get that procedure done. Working with the medical community as a whole to transition these patients through the system, as opposed to where it has been in the past, where things are very siloed. The nephrologists have their group and they're only going to see this. The GI doctors only have this. The cardiologists only have this. Well, and then the lack of communication between those, because one patient may have a cardiologist, may have a nephrologist, and may have a pulmonologist. They don't talk to each other. So the primary care doctor's role is to be the quarterback for that team and manage and coordinate between all these specialists what's going on. So what I'm seeing and what I'm hoping continues is the focus on that primary care to manage this system, this process with the patient.
And to treat more patients out of the
Out
clinic.
of the hospital.
Yeah, out of the hospital. Now, aside from that, how do you think healthcare delivery in general will change in the next 3 to 5 years? And two-parter, as the last question, what do you think community clinics, especially yours, needs to do to adapt and to better serve the patients?
So for the second part first, what we can do adapt to better patients is expand. So like I said, we have a very strict criteria, and one of our criteria is geographic. So and we are in the process of this. Originally, we were only our one county. We've now expanded that to 6 counties. And the reason for this is a lot of those outlying counties do not have a primary care physician office, any kind of specialty things, don't have a hospital. They may or may not even have a health department in some of these places. So that allows us to see more patients, get them in the system, to avoid the patient just going to the emergency room because, they want a cortisone shot for their foot. I had that last night. So that's the thing for that, for the community clinics, is expanding our services to have a larger footprint to see more patients. When we see more patients, that opens up the opportunity to get more funding. and then provide more services. So it's a cycle that we perpetually move forward. But we got to have the patients to do that and the providers to volunteer. Healthcare in general, back to the first part of the question, what I see in the next 3 to 5 years is the increasing role in AI. We're already seeing that a lot now, but I think it's just going to get more and more. From the scribe aspect to medical decision-making technologies, I'm still not a big fan of interpretive type studies, or services. Some things are great, but the EKG computer doesn't always recognize what an acute MI heart attack looks like. It says this, but it's not. So that's one thing that, no matter how much this AI and computer generated type things advance, the human aspect of medicine is not going to change. We still need to be there. We still need that human touch to connect with the patient.
It seems like no matter how great or effective it becomes, it always needs to be employed as a tool for the
Correct.
human element. And then that's what we've been preaching and talking about this whole time as well. So with that, I'd like to thank Dr. Matt Astin for joining us today on the Kind Intel podcast. Really appreciate you taking the time to share your insights and best practices with us. Hopefully you can get some rest after pulling that all-night shift in the ER. And with that, I'd like to thank you again, Macon Volunteer Clinic in Macon, Georgia, doing great work. Thank you, sir.
Thank you so much.